Can everyone see my slides?
Yes, you can see your slide. Thank you.
First, I just want to apologize for my voice. I'm still recovering from laryngitis. So I'm Dr. Lau, I'm HPV surgeon, and I'll be discussing the pancreas and spleen. So most of the details in the lectures will be coming from the book Short's Principles of Surgery. So for the pancreas, these will be the topics that will be discussed. So the pancreas is formed by the fusion of the ventral and dorsal and lateral. The ventral bud is forms the main pancreatic duct of Wirsung and also forms the inferior part of the pancreatic head and the insulin process, while the dorsal and lateral forms the accessory pancreatic duct of Santorini and also forms the body and tail of the pancreas. So the ventral and dorsal bud will fuse, forming the following regions of the pancreas. So the insulin process, which is behind the SMB and SMA, the pancreatic head, which is at the area held by the celiac of the duodenum, the neck of the pancreas, which is anterior to the SMB and SMA, the body of the pancreas, which is to the left of the SMB, SMA, and the tail of the pancreas, which is at the area of the splenic hilum. So the pancreas, as mentioned earlier, the dorsal and ventral bud will fuse, and this would also cause the pancreatic ducts of Wirsung and Santorini to fuse. So failure of the ducts to fuse causes a congenital anomaly, which we call pancreas divisum, which occurs in 10% of the population. As you have seen earlier, the duct of Wirsung comes from the ventral bud, which is smaller than the dorsal bud. So actually, the duct of Wirsung comes from a bud that is smaller than the Santorini. So failure of this to fuse means that a bigger part of the pancreas will have to drain through the duct of Santorini, which will drain into the lesser papilla. So because of this, patients with pancreas divisum are predisposed to episodes of pancreatitis. In 60%, the duct of Santorini persists, but it's still fused with the duct of Wirsung, but the duct of Santorini will drain into the lesser papilla. This is the most common anatomy, while in 30%, the duct of Santorini ends as a wide accessory duct. So the ampulla of Vater is on the medial aspect of the second portion of the duodenum, while the lesser papilla is 2 cm proximal to the ampulla of Vater. For the arterial anatomy of the pancreas, more or less the ones that I boxed in red are the critical anatomy. So we have the splenic artery, the gastroduodenal artery, and the superior mesenteric artery. So for the GBA, during the Whipple's procedure, we do test clamping of the GBA prior to ligation or division. This is to ensure that there is adequate flow to the hepatic arteries, because sometimes the flow to the hepatic arteries might mainly be coming from the pancreatic or duodenal arteries from the SMA. So to ensure that there's good flow despite the absence of, because in the Whipple's procedure, we will be removing the head of the pancreas, and that entails ligating and resecting the GBA. So So that's just one practical application of knowing the branches and the anatomy of the GBA. And for the SMA, what's important in this for pancreatic surgery is that there might be a replaced or accessory right hepatic artery coming from the SMA, and this will course behind the pancreatic head. So usually we check the anatomy pre-op by the CT scanner, the contrast enhanced CT scanner MRI, and we make sure that if there is a replace or accessory RHA, we make sure that during the surgery we do not injure this structure. For the venous anatomy of the pancreas, the critical structures that we usually encounter are in the area of the SMV above, anterior to that is where we do the tunneling of the neck of the pancreas. And that is a critical step during the Whipple's procedure. So as you all know, the SMV and splenic vein join to form the portal vein. During the pancreatic surgery, we also take note of the position of the INV, especially during distal pancreatectomy, since the INV usually drains into the splenic vein. So during distal pancreatectomy, since we ligate the splenic vein, of course we have to keep in mind to make sure that the INV is not inadvertently ligated. Other variations of the drainage of the INV is that it can also drain into the SMV and also to the junction of the SMV splenic vein. But the most common anatomy is the drainage into the splenic vein. For the lymphatics, the lymph node stations for the pancreas is actually the same as the stations for the gastric surgery. So I boxed in the lymph node stations that we encountered during pancreatic surgery. So the other lymph node stations that are in gray are already counted as non-regional lymph nodes. So in other words, presence of lymph nodes in those other areas are counted as metastatic disease. So for Whipple's procedure, I encircled the lymph node stations that are included for that procedure, and for the distal pancreatectomy, I encircled in orange the lymph node stations that we routinely include for that procedure. So for the histology and physiology of the pancreas, the pancreas has exocrine and endocrine function. The exocrine comprises 85%, while endocrine comprises 2%. The pancreas secretes 500 to 800 ml per day of pancreatic juice, and the important cells involved in this are the centroacinar and interrelated ductal cells, which secrete the water and electrolytes, including the bicarbonate, and the acinar cells, which secrete the enzymes and proenzymes. While the endocrine cells will be discussed in the succeeding slides. So we need at least 20% of normal pancreas to prevent pancreatic insufficiency. For the endocrine function, we have the iris of Langerhans, which comprises of several cells. The important cells include the alpha, beta, delta, epsilon, and the F cell. So the alpha cell, this secretes glucagon, beta cell secretes insulin, delta cell secretes somatostatin, epsilon secretes ghrelin, and the F cell secretes the pancreatic polypeptide. So, in medical school, they already taught functions of the cells, the hormones, so just review these. For the islet cell distribution, 70% of the total islet cell mass consists of the beta cells, and the beta and the delta cells are evenly distributed throughout the pancreas, while the PP cells or the F cells are increased in the head and insulin process, while alpha cells are more numerous in the body and tail. For practical application, because of the increased alpha cells in the body and tail, gluconeomas, which is a type of pancreatic neuroendocrine tumor, is also more common in the body and tail. So for the next portion, we will be discussing acute pancreatitis. For the pathophysiology of acute pancreatitis, one is intra-acinar activation, which so there's activation of the enzymes in the enzymes in the cell, which leads to autodigestion. Then another pathophysiology is there's inflammatory cell recruitment, which leads to increase in cytokines and eventually leading to local and systemic inflammation and multiple organ dysfunction and failure. For the etiology of acute pancreatitis, most of this will be due to gallstones and alcohol intake. Then other noteworthy causes include iatrogenic, which is a complication in 5 to 10% of ERCPs. Then other causes include tumors, which may account for 1 to 2% of acute pancreatitis. Then some medications can also cause acute pancreatitis, hypertriglyceridemia of more than 1,000 milligrams per deciliter, and hereditary pancreatitis. So for hereditary pancreatitis, the most common that are usually mentioned are PRSS1 mutation, which causes premature activation of trypsin, and the SPINK1 mutation, which causes loss of function. The SPINK1 is a serine protease inhibitor casal type 1, which inhibits trypsinogen activation. So loss of function of this inhibitor will lead to increased trypsin activation, hence leading to the pancreatitis. So for the signs and symptoms of acute pancreatitis, we all notice the abdominal pain is usually described as severe in epigastric invocation, often deviating to the back. Then the most common recall questions about this are the current sign, which is a bruise-like discoloration around the umbilicus, and the Turner sign, which is a bruise-like discoloration in the flanks. For the diagnosis of acute pancreatitis, we follow the revised Atlanta guidelines, which is you'll be able to diagnose acute pancreatitis if there is presence of at least 2 out of the following. So it's acute pain consistent with acute pancreatitis, abdominal pain consistent with acute pancreatitis, serum amylase or lipase greater than 3 times of the upper limit of normal, and characteristic findings of acute pancreatitis on imaging. And in addition to coming up with the diagnosis, you also have to determine the etiology of the pancreatitis. So for the workups, for the imaging, getting an ultrasound will help determine if the pancreatitis is due to biliary pancreatitis. So in other words, if it's due to gallstones. Then we also request for contrast-enhanced CT scan, though this is not routinely done. We usually request for this if the diagnosis is unclear, There's failure to improve clinically within the first 2 to 3 days after hospital admission and despite intravenous hydration. Then in other guidelines, the initial CD assessment, they recommend that it be done at least 70 to 96 hours after onset of symptoms. So with the CT, contrast enhanced CT scan, you'll be able to see if there are local complications, if there's necrosis of the pancreas, and you'll also see if there are other complications like during the arterial phase of the scan, you'll be able to see if there's any pseudoaneurysm or any active bleeding or hematoma. So for the types of acute pancreatitis, we have two types, the interstitial edematous pancreatitis and the necrotizing pancreatitis. So from the name itself, necrotizing pancreatitis, that means there's necrotic tissue. And you'll be able to diagnose this by a CT scan since there's you'll appreciate this with contrast enhanced CT scan since there's lack of pancreatic parenchymal enhancement, as you can see in the picture. So as you can see in this picture, in the body and tail, it's hypodense compared to this neck part. So you can more or less say that this area is necrotic. Then for interstitial edematous pancreatitis, there shouldn't be any recognizable necrosis. So as you can see in this scan, there's you can see the enhancement of the pancreatic parenchyma compared to the picture below. For the local complications, we have 4 local complications. 2 are under interstitial edematous, while 2 are under necrotizing pancreatitis. So if in interstitial edematous pancreatitis, there can be acute peripancreatic fluid collection, which in 4 weeks can lead to formation of pseudocyst. While in necrotizing pancreatitis, there can be acute necrotic collection, which in 4 weeks can lead to bulk of necrosis. So for any of these local complications, this can be sterile or infected. Usually for the infected, we appreciate this in infected necrosis, which peaks in the 3rd to 4th week after the onset of the pancreatitis. We suspect this if there's initial improvement of the patient, then there's eventual deterioration in the clinical course of the patient. Then we can also we can diagnose this by the presence of gas within the collection on CT scan. And this is confirmed by FNA, but FNA is usually not routinely done. So these are just pictures of the local complications. So for acute peripancreatic fluid collection, this is just fluid that you can see around the peripancreatic area, and this is for patients with interstitial edematous pancreatitis. Then in 4 weeks, this can develop into a pseudocyst. For patients with necrotizing pancreatitis, there can be an acute necrotic collection, as seen in the picture, which in 4 weeks can develop into a welt of necrosis. So in the picture, you can see there's a presence of gas inside the welt of necrosis, and as mentioned earlier, this signifies that the welt of necrosis is infected. For the severity of the pancreatitis, there are several scoring systems and several ways to determine if the acute pancreatitis is severe. Based on what I noticed, usually the internal medicine uses BISAP to determine the severity. While in our center, we usually use the revised Atlanta classification. So this divides the severity into three: mild, moderately severe, and severe. So for mild, there's no organ failure and no local or systemic complication. While for moderately severe, there's transient organ failure, which means this lasts less than 48 hours, and or local or systemic complications. While for severe, there's persistent organ failure, which means it lasts more than 48 hours. So for the revised Atlanta classification, to determine which, if there is organ failure, they use the modified Marshall score of more than or equal to 2. So the following are already the parameters that wherein we can already count the 2 points. For respiratory, there's a PF ratio of less than or equal to 300. For renal, there's a creatinine of more than or equal to 170 micromole per liter or 1.9 milligrams per deciliter. And for cardiovascular, there's a systolic BP of less than 90 that is not fluid responsive. Besides this, there's also the determinant-based classification for the severity, which divides the severity into 4. There's mild, moderate, severe, and critical. So for mild, it's the same as the revised Atlanta. For moderate, there's a transient organ failure, less than 48 hours, and or sterile necrosis. For severe, there's persistent organ failure, meaning more than 48 hours, or infected necrosis. And for critical, there's both persistent organ failure and infected necrosis. So for the determinant-based classification, they use the SOFA score of more than or equal to 2, which is more or less similar to the modified Marshall criteria. So for respiratory, there's PF ratio of less than or equal to 300. There's for the renal, creatinine of greater than or equal to 171 micromole per liter or greater than or equal to 2 milligrams per deciliter. And for cardiovascular, there's a need for anacropes. For the management of acute pancreatitis, we need to control the pain, we need adequate fluid resuscitation, and most guidance recommend moderate aggressive resuscitation with the aim to restore normal blood volume, blood pressure, and urine output. So with the fluid resuscitation, we want to have adequate circulation, but we do not want to cause fluid overload. Then some guidance recommend using lactated trainer solution. For the nutrition, oral enteral feeding is recommended, but we have to make sure that there's adequate resuscitation, because aggressive early enteral feeding before adequate resuscitation may put the patient at risk for non-occlusive mesenteric ischemia. For patients with organ failure, they should be admitted to the ICU. Regarding antibiotics, we don't routinely give antibiotics as prophylaxis. So we only give antibiotics if we are suspecting presence of infection. If the patient has cholangitis, then the patient will have to undergo ERCP, but the risks of ERCP include increasing the severity of the pancreatitis, the bleeding, the cholangitis, and perforation. For patients with biliary pancreatitis that are considered classified as mild, the patient may undergo cholecystectomy during the same admission. Then another part of the management is glucose control of the patient, since diabetes and prediabetes are common after acute pancreatitis and occur in nearly 40% of patients after hospital discharge. For the management of the local complications, first we have the pseudocyst. So Usually, pseudocysts will resolve spontaneously within 6 weeks, but if there's communication of the pseudocyst with the main pancreatic duct, and if there's presence of ductal stenosis, this may cause persistence of the pseudocyst. So with regards to the need for intervention, this would depend if the patient is symptomatic or if the pseudocyst is enlarging. So it is no longer based on the size and duration of the pseudocyst. Because previously we used to follow the 6 cm in 6 weeks cut off, but presently it's no longer followed. So we base more on the presence of symptoms. For the options for pseudocysts management, we have the endoscopic options, which include ES-guided transmural drainage of the pseudocyst or transpapillary stenting if there is pancreatic ductal communication. This is to decompress the cyst. Then other options include surgical drainage, which includes anastomosing the cyst into either the stomach or the duodenum or the jejunum. And another option is percutaneous drainage, which we avoid because there's a risk of causing external pancreatic fistula. For the next local contribution, we have infected ward of necrosis. So we have the most common procedures for this are the endoscopic transgastric drainage, and debridement, and the video-assisted retroperitoneal debridement. So for the endoscopic transgastric drainage, we will need an endoscopic ultrasound. So the endoscopist will be inserting stents from the gastric vein to the ward of necrosis. And through that, sometimes you just put a stent for drainage, but there are also times when they do debridement or necrosectomy through that communication. Then another is the video-assisted retroperitoneal debridement, which the surgeon does. So usually there's already a pigtail in place. Then you just you do a flat incision, a small flat incision, and follow the pigtail towards the area of the necrosis. So for the management, to decide what procedure to do, we follow the step-up approach. So the key thing you have to remember is that as much as possible, we try to delay doing the surgery until 4 weeks after the pancreatitis episode. This is to allow maturation of the wall of the ward of necrosis. So, if the patient initially presents with necrotizing pancreatitis and you're suspecting that there is infection, you treat the patient first with antibiotics. But if this is still inadequate, then the next step would be to do drainage, which is either percutaneous or endoscopic. If there's still ongoing sepsis, then repeat drainage is to be done. Once you hit the 4-week mark and there's still persistent infection, then that's when you do the guide or the endoscopic or the minimally invasive debridement. And if this still doesn't work, then the last resort is doing a laparotomy. So in this step-up approach, so you try to delay doing the surgery as much as you can by first giving antibiotics, first giving the drainage. Then when you hit the 4-week mark, that's when you're free to do the surgical options. of course, if there are situations such as abdominal compartment syndrome, presence of perforated viscous and hemorrhage, these are indications that will force you to do surgery at a much earlier timeline. Okay, so now we go to chronic pancreatitis. So the two theories for the pathophysiology of chronic pancreatitis include the centenary acute pancreatitis event and the multiple hit theory. So this is what happens. There's activation of the stellate cells, which causes collagen synthesis and leads to fibrosis. There's also stone formation in the pancreatic duct. So these are the common causes of chronic pancreatitis. We have the tiger or accident, toxic metabolic, which includes alcohol, idiopathic, genetic, including the PRSS1, SPINK1, cystic fibrosis, transmembrane receptor mutation, and CRDM2 mutation. Then we also have the autoimmune, recurrent severe acute pancreatitis, and obstructive, which includes pancreas division. So as mentioned earlier, pancreas division occurs in 10% of the population, and it is a congenital anomaly. So what happens is, since the duct of Santorini doesn't fuse with the duct of Wirsung, there's functional obstruction, since the duct of Santorini is smaller than the duct of Wirsung. And this would lead to the recurrent pancreatitis. And options for patients with pancreas division include stenting of the dorsal duct. So for the symptoms, we have the abdominal pain. This can be in patients wherein the pain is exacerbated by eating. We can deduce that this might be due to ductal hypertension, usually with means there are stones or strictures in the pancreatic duct. If there is chronic pain without exacerbation, this can be due to parenchymal disease in the pancreas, or there's a neural involvement in the retroperitoneum due to retroperitoneal inflammation. Then eventually there will be burned out pancreatitis, wherein there's severe destruction of the pancreas and there's evolution of painful to non-painful disease. So the goals of relieving the abdominal pain, the strategies include reducing secretion and or decompressing the pancreatic duct, resecting the area where there is chronic inflammatory change, and interrupting the nerves. For the other signs and symptoms, we have malabsorption and weight loss, which occurs when the pancreatic exocrine function is below 10%, which can lead to steatorrhea. And another complication is pancreatogenic diabetes. So these are ways to diagnose chronic pancreatitis. We have tests that involve measuring the endocrine and exocrine function, and we also have the imaging. So these are just imaging features of chronic pancreatitis. For the complications of chronic pancreatitis, we have pseudocysts, which is the most common, then pancreatic head mass, which can be benign, but there's focus of duct dural carcinoma in 3.7%. Then there could also be pancreatic enteric fistula, splenic and portal vein thrombosis, and another complication is cancer, which occurs in 1.5 to 6%. Then other complications include pancreatic ascites. This usually occurs if there's a disruption of the pancreatic duct.
Pancreatic ascites.
So strategies for pancreatic ascites include giving somatostatin analogs, complete paracentesis, and surgical therapy for those who fail to respond to medical treatment. For surgical interventions, you have to know first where the leak is coming from. If it's in the central area, then an option is to do a Wainwright pancreatical jejunostomy. If it's in the tail, then we can do a distal pancreatectomy. Then other management options for chronic pancreatitis. For the medical therapy, you have to advise the patient to stop alcohol intake, give pain relievers, give enzyme therapy, somatostatin analogs, and neurolytic therapy. We also have endoscopic options. This includes stenting and the pancreatic duct, pancreatic duct sphincterotomy, then pancreatic duct stones removal. So as mentioned earlier, for pancreas reducing, we can do stenting of the duct of Santorini and also minor papilla sphincterotomy. Then if medical options fail, we can also do surgical therapy. So one example is doing transduodenal sphincteroplasty. And the more common options for chronic pancreatitis include the resectional and the drainage procedures. So for resectional, we have the following are the most common. We have total pancreatectomy with or without autotransplantation, distal pancreatectomy, with this procedure, then the duodenum preserving pancreatic head resection, which include the following: the Berger procedure with the bone modification, the Curie procedure, and the Hamburg modification. So more or less for these four procedures, we will be calling out the head of the pancreas. There's just differences between the part. For the Berger procedure, the neck of the pancreas is transected, and for the bone procedure, the neck of the pancreas remains intact. Then for the Curie procedure, it's actually a hybrid procedure because it's both resectional and there's also a drainage part. So they will also, you will still call out the head, but not as extensive as the Berger and the bone. Then you will open the pancreatic duct and to drain the pancreatic duct and put anastomosis there. So keep the picture in mind so that you have an idea what is done in the mentioned procedures. For the drainage procedures, nowadays only the modified Bristol procedure is done. This is also called the Parkinson-Michel modification. So you open the pancreatic duct and you anastomose it to the jejunum. So this is done for pancreatic ducts that are dilated. So for this slide, I just showed the symptoms and what procedure should be done. So for patients with an inflammatory mass or fibrosis at the head, so the options are to do the resectional procedures. This includes the bone burger, and the Whipple's procedure. Usually, the Whipple's procedure is chosen if you're considering that there's presence of malignancy. Then, if there's less severe inflammation at the head, and also there's signs of obstruction of the pancreatic duct, meaning there's dilatation of the pancreatic duct, then you can opt to do the free procedure, which I mentioned is a hybrid procedure since it is both resectional and drainage. Then for patients that only have ductal dilatation without an inflammatory mass at the head, usually this is for patients with pancreatic ducts greater than or equal to 67 millimeters. You can opt to do the modified Bristol procedure or the otherwise called the Paddington Rochelle procedure. For patients with small pancreatic ducts, the options are to do a total pancreatectomy with or without islet cell autotransplantation and to do a V-plasty. For the next part of the lecture, we have the pancreatic cystic neoplasms. So these are the common cystic neoplasms. We have the serous cystodyma, which is benign. Then the pre-malignant cystic neoplasms, which include the mucinous cystodyma and the intraductal papillary mucinous neoplasm. The IPMN is divided into the main duct type and the branch duct type. So as you can see, if it is mucinous, that means it is pre-malignant. Then for the borderline, actually this is the solid pseudopapillary neoplasm is actually already considered a low-grade malignancy. So to differentiate the different cystic neoplasms, SCN usually is microcystic, has a central skull with some burst calcification. MCN occurs usually in females. It is macrocystic with peripheral calcification, usually at the body and tail. IPMN, for the main duct type, there's just dilatation of the pancreatic duct. While the branch duct type, there's dilated side branches. For the solid pseudopapillary neoplasm, usually the patient is a young female and there's solid and cystic contourments. So for the workups, we do imaging, CT, MRI, or EUS. Then we also, if there's still, we still don't, we cannot differentiate, then we do cyst fluid analysis. So, for one thing to note is if there's elevated cyst fluid CAA, that means the fluid is mucinous, which means the lesion is pre-malignant. So FCN is serous and has low cyst fluid CEA. MCN is mucinous, meaning it has high cyst fluid CEA. And usually the recall question for this is that there's ovarian-like stroma. For IPMN, it is also mucinous, so it has high cyst fluid CEA, and there's communication with the pancreatic duct, leading to high cyst fluid amylase and the appearance of the fish-eye appearance of the ampulla on endoscopy. Then for solid pseudopapillary neoplasm, there's low cyst fluid CEA and low cyst fluid amylase. For the management, for SCN, since it's benign, we only do resection if it is symptomatic. For MCN, there's some discrepancy in the guidelines. For the European guidelines, if it's greater than or equal to 4 cm or symptomatic or with high-risk features such as neuromerger, then they recommend resection, doing oncologic resection. For the Fukuoka guidelines, they recommend resection for all surgically fit patients regardless of the size. But if it is less than 4 cm and without neural nodule, then there's option of doing a parenchymal sparing resection. For the IPMN, the latest guidelines is the Kyoto guidelines. So It has they list down features divided into high-risk stigmata and worrisome features. For high-risk stigmata, they recommend resection. So it's the following include the presence of obstructive jaundice enhancing neural nodule of 5 millimeters or with solid component, mean pancreatic plaque greater than or equal to 10 millimeters, and suspicious or positive results of cytology. When there were some features, if there are multiple worrisome features or the patient is young and fit for surgery, they recommend resection. So the following are the worrisome features: repeated acute pancreatitis, elevated CA19-9, new onset or acute exacerbation of diabetes, cyst size greater than or equal to 3 cm, enhancing neural nodule less than 5 millimeters, thickened enhancing cyst walls, mean pancreatic duct 5 to 10 millimeters, appropriate change in caliber of pancreatic duct with distal pancreatic atrophy, presence of lymphadenopathy, and cystic growth rate of 2.5 millimeters per year. In the absence of high-risk stigmata or worrisome features, you can opt to do surveillance. So the recommended surveillance are the following: less than 2 cm, repeat imaging after 6 months, then every 18 months if stable. For greater than or equal to 2 cm to less than 3 cm, repeat imaging every 6 months twice, then every 12 months if stable. Then for greater than or equal to 3 cm, you have to do imaging every 6 months. Then for the European guidelines, it is more or less the same as the Kyoto guidelines. So the absolute indications are similar to the high-risk stigmata, while the relative indications are similar to the worrisome features, just with some slight differences. For the growth rate, instead of 2.5 millimeters per year, it's 5 millimeters per year for the European guidelines. And for the cyst size, instead of 3 cm, it is 4 cm for the European guidelines. Now we go to the pancreatic, the PANNET, or PNET. So we have the non-functional and the functional. For the functional, the most common are the insulinoma, gastrinoma, glucagonoma, somatostinoma, and the VLPoma. So the PANNETs are divided into well-differentiated, poorly differentiated, and the grading will depend on the mitotic rate and the Ki-67 proliferation rate index. So the succeeding slides are based on the latest NCCN guidelines for the PANNET. So this is version 1.2025. So for non-functioning PANNET, the recommended imaging workup include multiphasic CT or MRI, and the neuroendocrine tumors appear as hyper-attenuating lesions in the arterial and venous space. So for local regional disease, if it is less than or equal to 1 cm, you can opt for observation. Then 1 to 2 cm, the options are observation, in select cases pancreatectomy and enucleation. While for large lesions more than 2 cm with signs of invasion and or positive nodes, the recommendation is to do pancreatectomy, meaning doing a Whipple's procedure for the head, and for the body doing distal pancreatectomy with splenectomy. For the non-functional, for the functional PANNET, so these are the key features. For insulinoma, the clinical manifestation is hypoglycemia. For gastrinoma, it's peptic ulcer. VLPoma, it's watery diarrhea. For glucagonoma, it's diabetes and necrolytic migratory edema. For stomatostatinoma, you have diabetes, gallstones, steatorrhea, diarrhea. So for insulinoma, it is the most common. also it is mostly benign. Then for gastrinoma, it is the one with the highest association with MEN1 syndrome. So the surgeries are more or less, surgical management is more or less the same. It's just the difference is for insulinoma, since it is benign, you don't have routine lymphadenectomy is not required, and there's option for pancreas sparing. Then for somatostatinoma, since it causes gallstones, consider doing including a cholecystectomy. So I've mentioned these. Insulinoma, the recall question for this is the Whipple's triad, which includes symptomatic fasting hypoglycemia, glucose less than 50 milligrams per deciliter, and relief of symptoms with administration of glucose. So in the NCCN, the recommended workups include serum insulin, proinsulin, C-peptide, fasting blood glucose, then multiphasic CT or MRI. Then I underlined the selective arterial calcium stimulation test for localization. This is for patients wherein it's difficult to identify the location of the insulinoma. So in insulinomas, even though the lesion is small, it can be symptomatic. So usually we first do EUS if the lesion cannot be identified via regular CT or MRI. Then if it still cannot be identified with EUS, the other options include STR PET, which is somatostatin receptor PET, meaning we'll be using, I think in the Philippines what we have is the gallium dotatate PET. Then if it still cannot be, if the lesion still cannot be localized, then consider doing the selective arterial calcium stimulation test. For the surgery, if it's exophytic and peripheral, meaning it's not adjacent to the non-pancreatic duct, you can consider doing a tumor irrigation. Otherwise, do either a Whipple's procedure or a distal pancreatectomy. You can do spleen preserving since this is usually benign. So for the gastrinoma, this is also called the Zollinger-Ellison syndrome. As mentioned earlier, it causes peptic ulceration. Usually the lesion is located at the Passer's triangle in 70 to 90%. This is a triangle defined by the points located at the junction of the cystic duct and common bile duct, second and third portion of the duodenum, neck and body of the pancreas. So in the NCCN, the recommended workups include serum gastrin level, then multiphasic CT or MRI, and genetic counseling, since as mentioned earlier, it has the highest relation with MEN1. For the surgery, for occult or no primary tumor or imaging, you can observe or do an exploratory surgery including duodenectomy, IOUS, local resection, integration of tumor, and periduodenal node dissection. If it's located at the duodenum, then you do local resection with node dissection at the head, do a Whipple's procedure at the distal, meaning body and tail, a distal pancreatectomy with splenectomy and regional nodes. So for the succeeding factual tumors, since these have higher chances of malignancy, all the surgeries would already include doing an oncologic surgery, meaning there would be no dissection, and for distal pancreatectomy, this automatically includes a splenectomy. For glucagonoma, as mentioned earlier, there is a necrolytic migratory erythema, and it This is usually located at the body and tail, where there's a higher concentration of alpha cells. Based on NCCN, the recommended workups include glucagon, blood glucose, multiphasic CT or MRI. Then the surgery includes distal pancreatectomy, lymphadenectomy, splenectomy. For somastostatinoma, there's usually gallstones, diabetes, steatorrhea. The surgery there's no separate algorithm for this in the NCCN, and it was just mentioned that you follow the same as in non-functional PANNET. For VIPoma, the patient has severe watery diarrhea. So for the workups include VIP levels, electrolytes, multiphasic CT or MRI. Then for the surgery, repulse with lymphadenectomy, distal pancreatectomy with lymphadenectomy and splenectomy. For the surveillance, from within 1 year, you do multiphasic CT or MRI, chest CT. Then for functional tumors, do follow up with biochemical markers. More than 1 year to maximum of 10 years, do the diagnostics every 6 to 12 months. Then after 10 years, surveillance is clinically indicated. For advanced disease or metastatic disease grade 1 to 2, there is still an option for surgery if you can resect the metastasis and the primary. For symptomatic tumors, non-curative debulking might be considered in select cases, but usually this means debulking at least for non-functional at least 70%. Some guidelines now recommend 90%. So next we go to PDAC or pancreatic ductal adenocarcinoma. The most common mutation is the KRAS mutation, and the initial workups done is the pancreatic protocol CT or MRI. The lesion appears as a hypoattenuating lesion at the pancreatic and portal venous phases. Then additional workups include doing a chest CT, liver function test, and is CA19-9 after adequate drainage. Keep in mind that CA19-9 may also be elevated even in benign conditions such as biliary obstruction, inflammation, cholangitis, infections. So usually it is better to get the CA19-9 after adequate biliary drainage. Then it's also possible to have a negative CA19-9 even if there is presence of PDAC, because it is undetectable in Lewis antigen negative individuals. That is around 10% of the population. For patients with undetectable CA19-9 due to Lewis antigen negativity, you can consider getting a CA and a CA125 instead. For biliary drainage, this is not routinely done prior to surgery, but consider this if the patient has an infection, is in cholangitis, has severe pruritus, or if the surgery is being delayed. So this includes if the patient, if you would like to give neoadjuvant therapy prior to surgery. Then endoscopically placed stent is preferred over PTBD. If there is failure, the recommendation is to reattempt ERCP at a high volume center. If it's really not feasible, then options include PTBD versus EUS guided biliary drainage. Then self-expanded metallic stent is preferred over plastic stents. But for patients with very poor prognosis, wherein we expect less than 3 months survival, then you can consider giving just using a plastic stent. For the resectability, you have to memorize this to determine the anatomical resectability of the lesion. So for resectable, there's no arterial or venous contact. But if there's less than 180 degrees in contact but without vein contour irregularity, this can still be considered resectable. For borderline resectable, there's arterial contact of less than 180 degrees. Then venous contact of more than 180 degrees with contour or less than 180 degrees but with contour irregularity. For locally advanced, this includes or what we used to call unresectable. This includes patients with arterial contact of more than 180 degrees or involvement of the celiac axis and aorta. For the venous side to be considered locally advanced, this is that means the vein is not amenable to vascular reconstruction. So for resectable disease, if the patient does not have high-risk features, meaning the high-risk features include markedly elevated CA19-9, large tumor, suspected regional lymph nodes, excessive weight loss, extreme pain, and without the high-risk features, you can opt to do upfront surgery. And you do not need a biopsy proof of malignancy before surgery. Then with or without high-risk features, neoadjuvant therapy is also an option. Then obviously, if you're going to go for neoadjuvant therapy, you would need a biopsy and also a stent if the patient is jaundiced. In cases where you already opened up the patient, but it turns out that you can, the lesion cannot be resected, then you can do a gastric and a biliary bypass only if clinically indicated. So this is not, it is not automatic to do a double bypass. So for borderline resectable, you would have to do the advice is to do neoadjuvant therapy. So automatically you would need a biopsy and also biliary stenting if the patient is jaundiced in order for the patient to receive chemotherapy. For locally advanced, since the patient will not be undergoing surgery, we would need a biopsy, then genetic testing and molecular profiling. Then if the patient has a good or intermediate functional status, then you can give chemo-RT. So these are the common regimens. For neoadjuvant, we have FOLFIRINOX or modified FOLFIRINOX with or without subsequent chemo radiation. Then another option is gemcitabine with nab-paclitaxel with or without chemo radiation. Then, as mentioned earlier, neoadjuvant is given for borderline resectable and for patients that are resectable but with high-risk features. For adjuvant treatment, we give modified FOLFIRINOX or another regimen is gemcitabine with capecitabine. For locally advanced, these are the common regimens, so it will depend on the functional status of the patient. Then this is just the AJCC staging. So we need at least 12 lymph nodes as recommended by the AJCC staging. Though in certain journals, they recommend a higher lymph node yield. Then lastly, for the pancreatic surgery, I would just like to touch a little bit on the post-operative pancreatic fistula. So this is based on the ISGPS, International Study Group on Pancreatic Surgery. This is the 2016 update. So previously, This was diagnosed when there's a drain amylase of greater than 3 times the upper limit of the normal serum amylase. And this used to be called grade A. But in 2016, if the patient has a drain amylase 3 times elevated, but is otherwise clinically well, this was uh, changed to a biochemical leak. I mean, we now call this a biochemical leak. And if the patient has persistent drainage more than 3 weeks and clinically relevant change in the management, or the patient has to undergo uh, interventions such as percutaneous or endoscopic drainage, embolization, or if there is signs of infection without organ failure, we consider this a grade B pancreatic fistula. And if the pancreatic fistula causes reoperation organ failure or death, then we consider this grade C. For the spleen, just a very short discussion. The spleen is suspended by the several ligaments, splenochoric, gastrosplenic, splenic splenorenal ligament, and these are avascular except for the gastrosplenic, which contains the short gastric vessels. In the blood supply includes the splenic artery and vein and the short gastric vessels. And these are the indications of for splenectomy based on Schwartz. And usually we just, for the splenectomy, we just divide the attachments in the vessels. Just keep in mind to ligate the splenic artery before the drain. This is to allow safer manipulation, less bleeding, and to facilitate some shrinkage of the spleen. And also avoid injuring the pancreatic tail, which lies within 1 cm of the splenic hilum. Then, as you know, the splenectomy is for has immunologic functions, and so there's a risk for overwhelming splenectomy infection, which occurs in less than 1 to 5%. So to prevent this, we give vaccination to the patient. For elective cases, we give these 2 weeks free off, but for emergency cases like in trauma, these are given 2 weeks post-op. So these include the encapsulated bacteria, pneumococcal, meningococcal, and Anopheles influenza type B. And we also give the annual influenza vaccine. So that's it for the pancreas and the spleen.
Okay, thank you very much, Charlene, Dr. Lau.